Hey everyone, today we're diving into something you're going to use all the time on your rotations, examining a term newborn. Seriously, mastering this is absolutely key, so let's get right into it. Okay, picture this. You're on your peds rotation. A brand new baby has this swelling on its head. Is it a caput or a cephalohematoma? Does it cross the suture lines? Is this totally fine or is it a major red flag? These are exactly the kinds of high-yield questions we're going to nail today as we walk through the newborn exam from head to toe. Before we can even think about spotting what's abnormal, we've got to have a rock-solid idea of what's normal. So let's start with the basics. What exactly is a term newborn? Let's break that down. So a healthy term newborn checks three really important boxes. First, their gestational age is between 38 and 42 completed weeks. Second, their weight is over 2,500 grams. And third, they adapt to life outside the womb right away. They cry, they start breathing on their own. If even one of these isn't met, that's a signal to us that this baby needs a closer look and maybe some help. Now, that 2.5 kilogram mark is the official cutoff, right? But it's super helpful to know the average. For a term infant here in India, the mean birth weight is going to be right around 2.9 kilograms. Just a great number to keep in the back of your mind when you're on your rounds. And what about length? Well, you're looking at a typical range of about 50 to 52 centimeters. Now, listen up, because this is a classic exam question, a real clinical pearl. A baby's weight can be all over the place, right? It's affected by things like maternal diabetes or growth restriction. But length? Length is often a much more stable and reliable clue to the baby's actual gestational age. Definitely remember that. Okay, so the baby is born. What happens in that very first minute? What's our immediate job? We need to see how well they're making that huge transition to life outside the womb. And the tool we use for that, the gold standard, is the APGAR score, developed by the amazing Dr. Virginia APGAR. So the APGAR score looks at 5 things, and each one gets a score from 0 to 2. Simple enough. We do this at 1 minute, and then we do it again at 5 minutes after birth. Now here's how I want you to think about it. That 1 minute score, it's like an emergency snapshot. It tells us who needs help right this second. But the 5 minute score, that one tells a bigger story. It's much more predictive. If that score is still low at 5 minutes, that's a much bigger deal because it's more strongly linked to long-term neurological outcomes. And that's why the APGAR isn't just some number we write down in a chart. It's a call to action. It directly guides what we do next. You can see it right here in the neonatal resuscitation algorithm. If that score is low because the heart rate is under 100, boom, you start positive pressure ventilation. If it's really low, under 60, you're starting chest compressions. See, the score literally tells you what to do. It's a direct link to those critical, life-saving steps. All right, so the baby's stable, everything's good. Now it's time for the full physical exam. And the absolute key here is to be systematic. Do it the same way every single time. So let's walk through that head-to-toe approach together so we can build a really complete clinical picture. First up, vitals and skin. For breathing, you're looking for about 30 to 60 breaths a minute. For heart rate, somewhere between 100 and 160 is our happy place. Now, skin color is without a doubt one of the most important things to check. If the baby looks pale, you're thinking anemia or maybe even shock. If they're really, really red, we call that plethora. It could be a sign of polycythemia, which just means too many red blood cells. And then there's central cyanosis, a blue tongue and lips. That is always a red flag. Get help immediately. And of course, we have to know the difference between these scary things and the totally normal stuff like little white Melia spots or Mongolian spots. Those are benign. Another big one for skin is jaundice, right? That yellowish color. You'll start to see it when the bilirubin level gets above about 5. We can actually get a pretty good estimate of how high it is just by looking, using something called Kramer's rule. The key thing to remember is that jaundice spreads from head to toe. That's what cephalocaudal means. So if you see that yellow color all the way down on the baby's palms and soles, that's zone 5, you can bet the bilirubin level's probably over 15, and that baby needs an urgent workup. Okay, let's move on to the head. You always want to gently feel the fontanelles, the soft spots. If it's bulging out, that could mean increased pressure inside the skull. If it's sunken in, think dehydration. Now, checking the chest, you might see some breast enlargement, maybe even a tiny bit of milky discharge. We call it witch's milk. Don't panic, it's totally normal, just from mom's hormones. What's not normal, though, is a scaphoid or sunken abdomen. That's a major red flag and could point to something serious, like a diaphragmatic hernia. Next up, the umbilicus. Take a close look at the cord. You're looking for 2 arteries and 1 vein. 2 arteries, 1 vein. If you only see a single umbilical artery, that's another one of those big red flags. It can be associated with congenital anomalies like trisomy 18. Then we check the genitalia. For a term female, the labia majora should cover the minora. And again, don't be surprised by a little bit of bloody discharge. That's just normal withdrawal from mom's hormones. For a term male, it's pretty straightforward. You just need to confirm that both testes are down in the scrotum. All right, let's get back to that big question from the start, the one that honestly trips up almost everyone. You see that swelling on the baby's head. How do you know for sure if it's a caput or a cephalohematoma? This is so high yield for your exams. So let's make this distinction absolutely crystal clear. Okay, here it is. The single most important thing to tell them apart. A cephalohematoma does not cross suture lines. A caput does. So why? Well, it all comes down to the anatomy. A cephalohematoma is a bleed under the periosteum, which is the tough covering of a single skull bone. And that covering is stuck down tight at the suture lines, so it acts like a fence. The blood can't get past it. A caput, on the other hand, is just puffy swelling or edema in the scalp tissue above the bone. So there are no fences. It's soft, it can pit when you press on it, and it can easily spread right across those suture lines. If you take away just one thing, make it this. A cephalohematoma respects the suture lines. Whew, we've gone through a lot, haven't we? So let's boil it all down. What are the absolute must-know, high-yield points that you need for your exams, and more importantly, for when you're on the wards? Okay, here's your high-yield summary. Ready? Term infant, 38 to 42 weeks, and over 2.5 kilos. APGAR score, you're checking at 1 in 5 minutes, and it guides your resuscitation. Your top 3 red flags to never ever miss: central cyanosis, a single umbilical artery, and a scaphoid abdomen. Head swellings. Cephalohematoma is stuck behind suture lines, caput is not. And finally, remember the normal stuff you don't need to worry about, like Mongolian spots and witch's milk. So, to wrap this all up, it comes down to 3 simple things. 1, know what normal looks like. 2, use the APGAR to assess their transition to the world. And 3, be systematic with your head-to-toe exam. If you can do those 3 things, you'll be able to confidently and safely evaluate every single newborn that comes your way.